Good afternoon, all. First of all, I would like to thank Dr. Abdullah and Saranakumar sir for giving me this opportunity. Today, my topic is various surgical options for the distal thumb soft tissue injury and its importance. See, before going to the topic, we are going to talk about the anatomy of the thumb and also functions of the thumb. See, thumb consists of 3 bones and 3 joints. One is distal phalanx, proximal phalanx, and metacarpal bone. And 3 joints: carpometacarpal joint, metacarpal phalangeal joint, and interphalangeal joint. See, at the carpometacarpal joint level, the opposition, the unique function of the thumb compared to the other finger, the opposition is the unique function of the thumb, which will occur at the carpometacarpal joint level. Totally 8 muscles are inserting into the thumb. 4 intrinsic muscles and 4 extrinsic muscles are inserting into the thumb. Intrinsic muscles originates from the hand, mainly the thenar muscles, 3 thenar muscles and 1 adductor pollicis muscle. Thenar muscles are opponens pollicis muscle, abductor pollicis brevis, and flexor pollicis brevis. These 3 muscles are supplied by the median nerve, and 1 adductor pollicis muscle is supplied by the ulnar nerve. Then there are totally 4 extrinsic muscles are inserting into the thumb. One is a flexor pollicis longus inserting into the distal phalanx, and extensor pollicis longus, extensor pollicis brevis, and abductor pollicis brevis. These muscles are inserting into the thumb. So, based on the site of the injury, thumb injury classified into the 3 types: distal thumb injury, and middle 1/3 injury, and proximal 1/3 injury. So, today we are going to talk about the distal 1/3 of the thumb injury. What is distal thumb? Distal to the IP joint, which consists of distal phalanx, and there will be an insertion of the flexor pollicis longus at the base of the volar side of the distal phalanx, and the extensor pollicis longus tendon inserting into the extensor aspect of the base of the distal phalanx, and there will be a pulp of the finger which cover the both tendon and bone in the volar aspect, which is pulp of the finger, which consists of dermis, epidermis, and also the fat globules. Through the fat globules, there will be a septa which is running from the periosteum to the dermal component, which will prevent the mobility of the pulp of the finger. And there will be a dorsal side, there will be a nail and nail bed is there, which will support the pulp of the finger. So, this is the basic anatomy of the thumb and distal thumb. So, now coming to the functions of the thumb. Thumb approximately carries 40 to 50% of total hand function. So, there are 5 main functions are there. One is opposition and power grip, precision grip, and key pinch. Then the tactile sensation. See, opposition mainly done by the opponens pollicis muscle, which occur at the CMC joint level. It's a combination of 3 actions, mainly palmar abduction, medial rotation, and flexion, so that only our thumb will come in contact with the palmar side of the hand and fingers. So, this is the unique function of the thumb. Then grip, power grip. For the power grip, we need to hold the heavy object with the help of the fingers. In the same time, our thumb will act like a post, and at the same time, our IP joint will flex and strengthen the power grip. Then coming to the precision grip. For precision grip, we need a tip to tip and pulp to pulp contact. For that, we need a opponens pollicis muscle action and also flexion and extension of the IP joint. Then only we can hold the pen and pencil, and also we can do fine manipulations like buttoning the shirt and writing and drawing. And other than that, key pinch also we need a distal thumb. We need a counter force of the thumb against the radial side of the index finger. Then only we can hold the key like object and we can manipulate the key. So, these are the main functions of the thumb. Then there will be a special sensation over the thumb. There will be mechanoreceptors like Merkel cells Bessonian's corpuscles and Ruffini cells are there, which is responsible for the textured sensation. Because of that only we can sense the softness and hardness of the object, and also we can sense the shape of the object. So which will be more in the thumb and the index finger, pulp of the index finger also. So thumb injury is particularly more common because of its prominent and high function. The chances for injury will be more. So we must effectively treat the distal thumb injury to preserve the functions what we mentioned before. So various surgical options are there. One is VY advancement flap, Moberg flap, composite grafting, first dorsal metacarpal artery flap, cross finger flap, and the insert grafting. So these surgical procedures were chosen mainly based on the site of the injury and the amount of tissue loss and the amount of tissue availability in the thumb. Then exposure of the vital structures like tendon and bone. This is the case one, a 5 years old child with crush injury. On examination, patient presented with distal pulp of the injury. The distal soft tissue was lost. For that we did a Moberg flap. For that we put an incision in the bilateral mid-lateral line incision. The flap elevated along with the neurovascular bundle of the thumb, just above the paratendon of the flexor tendon. See here you can see the flexor tendon, just above the paratendon, flap elevated, and the flap advances to the defect. Only disadvantage is the advancement will be very minimal, only 2 centimeter. So sometimes we need to flex the IP joint to get a adequate reach. This is our case. We elevated the flap along with the neurovascular bundle. We also did a flexion of the IP joint. This is the immediate post-operative picture. Flap insert given. The late post-operative picture. This flap provided a good durable sensate cover and also like with like cover. The same glabrous skin cover was given. This is the second case, a 34 years old female with accidental cut injury. Patient presented with gangrenous changes of the dorsum of the thumb. So we did a wound debridement, following which extensor pollicis longus tendon was exposed. So that is vital structure. We need to cover that extensor pollicis longus tendon. So we did a flex first dorsal metacarpal artery flap. The flap elevated from the dorsum of the index finger, mainly based on the first dorsal metacarpal artery, which is a branch of radial artery. Just distal to the snuff box we elevated. This is the intraoperative picture. Flap elevated from the index finger along with the epimysium of the first interosseous muscle. Because first dorsal metacarpal artery passing through that epimysium. So flap elevated, flap transferred to the defect. This is the immediate post-operative picture. The donor site was covered with the full thickness graft which was harvested from the groin region. This is the late post-operative picture. The flap settled well and also the donor area also settled well. This flap also provided a good durable skin, the same like with like cover. So this is the advantage of this flap. This is the third case. A 16 years old male patient had a accidental cut injury. Distal pulp of the thumb was lost. We did a wound debridement. Following the wound debridement, VY advancement flap was done. See, V-shaped incision was given. Only epidermis and dermis was cut. After epidermis and dermis was cut, we can see the septa. We already told there will be a connection between the periosteum and the dermis. We cut the septa so that it facilitated the advancement of the flap. The flap advances to the defect, flap insert given. So This is the V-shaped incision. We are not cutting the fat here because the flap getting blood supply from the digital vessels through the multiple capillaries which is passing to the fat globules. So we are not touching the fat only, we are cutting only the septa and the epidermis and dermis. So flap advances to the defect. This is the late postoperative picture. The flap settled well. This flap also give a durable cover and also same color was not mismatched. Then this is the fourth case. So here we did a two-stage procedure. Since there will be a dorsal and volar side defect was there, 14 years old male patient. So we did cross finger flap from the index finger. In the first stage, the flap elevated, distally based flap was elevated, insert was given, the donor site was covered with the full thickness graft which was harvested from the groin region. After 21 days, the flap division was done. This is the late postoperative picture. Flap settled well and donor site also settled well. The only disadvantage is color mismatch was there, but we can preserve the suboptimal sensation after 1 year of period. Patient didn't develop any textured sensation in that area, but the patient will develop suboptimal sensation like pressure and pain sensation patient can develop. This is the case of fifth case, 25 years old male patient with the degloving injury. There was no adequate skin in the same thumb and adjacent finger to cover the entire raw area. So we did a groin flap from the groin region mainly based on the superficial circumflex iliac artery. After tubing the flap, flap insert was given. It's a two-stage procedure. After 21 days, the flap division was done. This flap also provided a good cover, but only disadvantage, it's a two-stage procedure and color mismatch was there. Sometimes it will be a bulky flap, so we need a third procedure like flap thinning. And the sixth and seventh case were grafting. So 41 years old male patient presented with a cut injury and the amputation of the pulp of the finger. The bone was not exposed. So we did a defatting of the amputated segment to prevent the metabolic demand so that the graft will take. The graft insert given. This is the late postoperative picture. Graft took well. The seventh case, a 22 years old male with a crush injury without bony exposure. The soft tissue was covered with the instep graft which was harvested from the sole of the foot. Intermediate layer of the dermis was taken and insert given. The donor area is covered with the epidermis and part of the dermis. So both donor site and recipient site settled well. This is the late postoperative picture. So if we preserve the 50% of the distal phalanx along with the FPL insertion, flexion and along with the extensor pollicis longus for extension, we can preserve the fine grip and the tactile sensation and we can preserve the strength of the power grip. So try to avoid the shortening closure in case of distal thumb injury. Thank you.